So this lectorial is going to cover some aspects of prostate pathology for you. We remind ourselves, of course, that the prostate is situated in the true pelvis, has a very intimate relationship with the base of the bladder. Anteriorly, it's bound by the symphysis, inferiorly by the urogenital diaphragm on which it sits, and posteriorly has a very close relationship with the rectum. The prostate gland in the young adult is not too large, weighs about 20 grams. As we'll see, however, though, the weight of the gland increases as men age. This is technically an exocrine gland. It's a tubuloalveolar gland, and its main purpose is to make prostatic secretions, which comprise about 30% of the ejaculatory volume. These contain a number of enzymes and elements which assist with sperm motility, together with modulating the pH of the ejaculate. The gland is made up of a number of zones. You can see a model of the different zones of the gland in the figure. So the figure reminds us that the prostate gland is a sort of inverted cone-shaped. There is a zone around the urethra as this passes through the gland, sort of demonstrated by the blue area. This is the central zone. This is a transformation zone, the orange zone around this. And then again, beyond this again, making up the majority of the gland is the peripheral zone. So this is an axial slice of the prostate gland, and sort of highlight the two major zones. So we've got a sort of central zone which surrounds the inverted V-shaped urethra, which you can see in the middle of the gland, and I've highlighted there the outer or peripheral zone of the prostate. Why are we interested in these zones? Well, they're important because the two main pathologies of the prostate gland, that is prostatic hyperplasia and prostatic carcinoma, involve the different zones. So prostatic hyperplasia tends to involve that central zone, whereas prostatic carcinoma will involve the peripheral zone. Down the bottom of that slice you can see two curved arrows, and they're in the area of the rectum. So you can see that from the rectum it is possible to palpate the peripheral zone of the prostate with some ease. So let's then talk about prostatic hyperplasia. Prostatic hyperplasia involves that central zone. So we can see the blue zone there. So in prostatic hyperplasia, under hormonal influence, there is expansion and increase in size and volume of that central or blue zone. And again, there's some axial slices of the prostate gland to show that if we look, for instance, at the image on the bottom left, the arrow there marks the little bit of the compressed peripheral zone, and we can see that the central zone has been enormously expanded by these nodules of hyperplastic prostatic tissue. And on the bottom right image there, the curved blue arrow marks the compressed urethra, compressed by these nodules of hyperplastic prostatic tissue. So nodular hyperplasia of the prostate is a very important cause of morbidity in older individuals. That's extremely common. So up to half of all men in their 50s will demonstrate significant prostatic hyperplasia, and as one gets older, it becomes an almost universal phenomenon. So as I've said, these hyperplastic nodules are really involving the central zone, so they tend to be centered on the proximal prostatic urethra in the area of the central and transition zone. So the significance of this is, of course, that this benign enlargement of the central zone of the prostate that we call prostatic hyperplasia leads to significant lower urinary tract symptoms. And these are either obstructive in nature or irritative, or a combination of both. So the usual obstructive symptoms will be those of sort of hesitancy, straining to flow, poor flow, taking a long time to void, inability to completely empty the bladder, and irritative symptoms, which will be sort of frequency, urgency, and nocturia. So the normal histology of the symptoms associated with prostatic hyperplasia, as we've said, can be quite significant. So treatment of this either involves first-line medical treatment, so usually some adrenergic receptor blocker to reduce smooth muscle tone, and this can often assist with improving urinary flow and outlet obstructive symptoms. However, in some individuals they require surgical treatment, and this usually involves a procedure called a transurethral resection of the prostate. So one uses a modified cystoscope with a cutting loop on the end, and this is used to resect out that central and transitional zone of the prostate, leaving the peripheral zone in place. And you can see there on the right is the image obtained through the cystoscope. The left hand image shows the central zone with obstructed by the nodules of hyperplasia, and the other image shows what it looks like after this central zone has been resected. The second disease, of course, we want to talk about is carcinoma of the prostate. This has risen to considerable public interest with activities from the organisations such as the Prostate Cancer Foundation. Why are we interested in prostate cancer? Well, because it is the number one cancer by a long stretch for New Zealand males. If we look there, we can see it is the most common cancer. It is certainly more than double the incidence of the second most common cancer, which will be colorectal cancer. And if you compare it with the incidence of breast cancer in females, you can see that the numbers even outstretch of female breast cancer in terms of incidence. So it's a very significant disease in our community. Carcinoma of the prostate is uncommon below the age of 50 years, but the incidence rises dramatically with age, and still 3/4 of all prostate cancers are occurring in patients over the age of 65. The incidence of prostate cancer varies quite markedly across various geographic areas, but it is much more common in developed nations, and in fact Australasia has the world record at the moment for the highest incidence of cancer of the prostate. Some of the remarkable increase in the incidence of prostate cancer is of course due to detection bias. With screening and what have you, we've been looking much more closely for prostate cancer, and obviously the more closely we look, the more we're likely to find it. Prostate cancer does have a genetic basis, and there's a very well documented familial association, and if you've got a first degree relative with prostate cancer, then you've got up to 10 times increased risk of developing prostate cancer yourself. Environmentally, prostate cancer has a very strong association with diet, particularly diets which are rich in animal products and red meat, and this probably explains the very high incidence in developed countries such as Australia and New Zealand. So prostate cancer is a relatively insidious disease, and in fact the majority of patients now with prostate cancer are diagnosed not because they have symptoms, but because they come forward for PSA screening. So those patients who are symptomatic with this disease usually have advanced disease at the time of presentation. So these are people who have obstructive symptoms or pelvic pain or bone pain, evidence of spinal cord compression or adenopathy. So the main indication really for patients to have a biopsy to see if they have prostate cancer is firstly detection of an increased serum PSA, prostatic specific antigen level, and or an abnormal digital rectal examination which reveals palpable nodules, asymmetry or induration in the posterior part of the gland. So remember that PSA is synthesized by both the benign and malignant prostatic glands and ducts, and so even in patients who have benign hyperplasia of the prostate, we're going to see an increase in the serum PSA levels. So traditionally we've set a cutoff of about 4, and over this level then biopsies of the prostate are recommended. However, even setting that cut level, we're still going to have a false negative rate of about 20% and a false positive rate of 30%. So PSA screening is not the world's most sensitive or specific tests. There are attempts to improve its sensitivity. We, for instance, will measure PSA density, which adjusts the PSA for the volume of the gland. We've introduced sort of age-specific ranges, and sometimes we look at PSA velocity. So that's not to say what's happening with a single PSA measurement, but looking at the rate of change of PSA over time with subsequent measurements. Notwithstanding, PSA screening has always been and remains highly controversial. Why is it controversy? Well, firstly, they've got the sensitivity and specificity issues I talked about, and it tends to result in the detection and treatment of many prostate cancers that may not progress, or if they progress very slowly and in fact won't cause the death of the patient. So detection of many of these cancers risks the problem of over-treatment, and then this might outweigh in fact the benefit of detecting some cancers. Plus we've got studies which show really that there's no long-term reduction in the mortality for men who have PSA screening compared to men who don't. So the best method then to detect prostate cancer in people with abnormal PSA is to biopsy the prostate gland. The easiest way is to do this transrectally, so one uses an ultrasound probe and a biopsy needle and obtains between 6 and 12 cores from the prostate tissue, which is sent to a pathologist for examination. Increasingly in vogue now is biopsy by the transperineal route, which we can see that illustrated there on the right. The advantage is that you can get better targeting. You can get into the anterior parts of the prostate, which you may not easily get to with the transrectal approach, and there's much less risk of introducing infection and prostatitis. So in those biopsies, our job as pathologists is to identify the presence of cancer and also to grade the cancer which is there. And there are grading systems which are primarily architectural. And so a typical grade group pattern 1 is illustrated there on the left with sort of small microacini. Grade group 4 pattern shows much more cribriform and compact growth, and grade group 5 is solid in its appearances. So the aim of all of this is to try to detect prostatic cancer which is organ confined. So stage 1 and 2 disease represents cancer of the prostate which remains confined. In stage 3, cancer spread beyond into structures such as the seminal vesicle and the local extraprostatic tissue, and in stage 4 it's more widespread. So it's much more problematical obviously in a situation as is illustrated in the X-ray where we've ended up with sclerotic bone metastases and bone pain as in fact the first presentation of prostatic cancer. So prostatic cancer treatment is quite interesting and it's confusing because there are many different modalities that are available, and sometimes the best treatment for some types of prostate cancer is no treatment at all. And so now we're much more moving to a tailored treatment plan, which is based really on the individual characteristics, the age of the patient, their comorbidities, the grade and the stage of the cancer, their serum PSA levels, and the like. So for many low-grade, low-stage, low-volume tumours, we're now using a procedure called active surveillance. So here the prostate cancer is diagnosed by prostatic needle biopsies, and the patient is followed up with subsequent perhaps MRI and further biopsies to see that the tumour remains low stage, low grade, low volume. If there is if the tumour fails on any of those criteria or over follow-up, then one can move to using external beam radiotherapy or brachytherapy, or move to removing the prostate through open or robotic prostatectomy. Very trendy now is brachytherapy for treatment of cancer rather than using external beam. So what one does is carefully map out the areas of prostate cancer by imaging, and using a device that you put on the perineum of the patient, you carefully introduce these rods into the gland and introduce little radioactive seeds which remain in the gland, and you can see the X-ray of these seeds after they've been introduced. The mainstay of surgery though remains radical prostatectomy. Increasingly now this is being done endoscopically and robotically. The aim is to remove the prostate gland, but to try and leave the neurovascular bundle that runs alongside the gland intact, because the damage to this will seriously have effects on erectile function. So the image on the bottom right there shows a whole prostate gland that's been removed. I've sliced this up in an axial way, and we can see the blue area there marks an area of prostatic cancer in the peripheral zone in the mid aspect of the gland. So just highlighting that compared to hyperplasia, which is a central process, most carcinoma of the prostate is involving that peripheral zone. For non-organ confined disease, again there's the potential to use external beam radiotherapy. Many prostate cancers, at least in their early stage, are androgen dependent on growth, and so there are various treatments one can use for androgen deprivation. Previously that used to involve bilateral orchidectomy. Now we have anti-androgen drugs, and so this can slow the development of non-organ confined disease. But eventually the majority of these tumours become resistant to anti-androgen therapy, and so they become so-called castrate resistant cancer, and there are various chemotherapies available for these individuals. Thank you.